was IC and Dr. Prof for including me in the list of the faculty slides. So in the morning every day on the surgery day we have a discussion for about half an hour about, in the case of vitreous hemorrhage, we usually ask our residents what are the possibilities, especially when we don't know what the cause of vitreous hemorrhage is, and usually have a list of differential diagnosis. But many times the actual condition which would have caused the vitreous hemorrhage would be different from the list. It would not be in the list of the differential diagnosis, and that is what I'm going to talk about. A mix of those in the differential diagnosis list and those which are not. So this is a case of a 59-year-old gentleman, 12 years, diabetic, sudden loss of vision, right eye, no view due to vitreous hemorrhage. So 12-year diabetic, you know that it is usually a PDR that has caused vitreous hemorrhage. The B scan showed a retina attached, no proliferation seen. The other eye showed mild to moderate NPDR changes, or maybe severe NPDR changes, all the more giving us reason to guess that the cause of vitreous hemorrhage is PDR in this eye. So anti-VEGF was given. It was at a time when we were giving routinely 5 years ago or 6 years ago. Nowadays we don't give anti-VEGFs routinely for all vitrectomies, and vitrectomy was done. And on the table we found that there was no retinopathy, not a single dot hemorrhage or a microaneurysm in this eye with vitreous hemorrhage. And then we had to indent and see the periphery, and we found a small peripheral HST along the vessel, which was actually the cause of vitreous hemorrhage. So it need not always be diabetic retinopathy. We have retinopathy in the other eye, we have a history of diabetes, and we always presume that this could be vitreous PDR, but this case showed that it sometimes can be wrong. So, and lessons from this case: anti-VEGF was not needed. History of flashes probably could have helped and could have been elicited. A small flap could have been looked for on USG on careful examination, and a post-operative FFA for a clinically normal fundus is something that we should think about to rule out a PDR in this eye which looks normal, something like a featureless retina, which we might be dealing with. Case 2, loss of vision in the left eye of 1 week's duration, no systemic illness, B scan, no RD. He was advised and underwent surgery, and this is what we found on the table: retinal detachment with a large tear, and so this is the tear that is being lasered. So an RRD was found intraoperatively. No systemic illness, no history of trauma, nothing, and this is what we found. So this is another surprise that we had, or unexpected eventuality that we had on the table. This again is an ochre colored blood, which is a breakthrough hemorrhage from a peripheral VSCR that we diagnosed intraoperatively. In the case of vitreous hemorrhage, the B scan was not available with us. The patient was refusing a B scan because he had undergone a B scan elsewhere, and that B scan showed only the posterior pole, which was not showing any retinal detachment or a mound. So this is what we found on table, and it was managed, no doubt. If we had probably anticipated that there was a peripheral exudative hemorrhagic retinopathy, we would have probably managed it in a better way, but we ended up with a large tear, which we fortunately could manage well. So never venture without a USG report from outside. This is a lesson that we learned from that patient. Case 4 is of a 50-year-old female with no systemic illness, gradual loss of vision since 3 months, vision reduced due to vitreous hemorrhage, and posterior synechiae was present. You can see the posterior synechiae in this eye. There was vitreous hemorrhage, and the disc was hazily seen. Ultrasound showed no retinal detachment. So this is the video of the patient who underwent with the uveitis signs in the anti-segment posterior synechiae. And you can see the fundus is nearly normal, but when we looked at the periphery, we found this scleron-like appearance. We induced a PVD, did a posterior vitreous detachment induction, and see those white dots. Some of them are actually IVT crystals, but most of them are inflammatory deposits on the retina. We did an indented base shaving and found that there was no evidence of vasculitis or vascular abnormalities. This again is a diagnostic element. We don't know the cause of vitreous hemorrhage. This could be just a PVD causing a vitreous hemorrhage in a uveitis patient, coincidental to the uveitis. So this is another case which teaches us a lot of things. Case 5, a 62-year female with sudden loss of vision, 1 month, diabetic since 10 years, other eye severe PDR. When this is the status of the other eye with severe PDR, we would expect that the other eye also would have a PDR. But during vitrectomy, what we found was something else. We found that there was no diabetic retinopathy, like in the first patient with the retinal tear. This was actually a case of superior temporal BRVO with no diabetic retinopathy changes. In fact, there was no neovascularization to explain the cause for the vitreous hemorrhage, and probably this was a case of PVD. We really don't know what the cause of vitreous hemorrhage was, although we presume that this could be due to a BRVO. So this is the fundus finding. We did a laser, no doubt, just to overdo and see that there is no scope for further bleeding. Case 6 is another case of vitreous hemorrhage. In a phakic eye, you can see the vitreous space being filled with blood, and this is what we found on table. A large hemorrhage, subretinal hemorrhage, sedation, and elevation of the retina. So this is something that we can have, and if a proper ultrasound is done before the surgery, we can pick up these findings. So PCV with breakthrough hemorrhage is what this patient had. Post-trauma with RD on USG is something that we had in the beginning of the surgery. We saw that there was RD, but this was more than a month old, and there was this incarceration of the retina which could not be detected on the B scan. So maybe it was a very small scleral tear into which the retina had got incarcerated, causing RD, and this was something that we had to relieve by retinectomy, and I'm sorry, a poor video, but then that was what it was. Other coincidental findings that we may have on during vitrectomy are macular hole, like in this patient. Which was managed by LM peeling. You can have ERMs, you can have EMT, you can have intraoperative multi-layered hemorrhage in a breakthrough vitreous hemorrhage in RAM patients, which are also coincidental findings during vitrectomy, which we would not have diagnosed before surgery. Masquerades of DR are another set of causes of vitreous hemorrhage. Anemia, myeloproliferative disease, and so on are very, very common. And like Dr. Diraj mentioned in his talk, we have to evaluate these patients. At least a CBC, total blood count, helps us a lot in eliminating the likely cause of a myeloproliferative condition. So in summary, the vitreous cavity is a cavity of uncertainties. Preoperative diagnosis is a challenge. In some patients, you can never be sure of the cause every time, and surprises are quite common. Thank you very much.